We're now being recorded, and welcome to Blood and Lymph session. So these are our learning objectives. And a lot of this will relate back to not only sort of the academic needing to know, but also to in the future when you're out and about and you're going out to some of those slightly more complicated patients who come with a whole handful of notes, and you're flipping through those notes and you're going, okay, what is actually going on with you? And they're not 100% certain themselves. Okay, so I'm sure on placement you'll have encountered some of these patients. So this should help a bit with your interpretation of those. So we're going to be going through saying what's actually in blood, what's actually in plasma, especially as we've been talking about that a lot recently, and what's important about red blood cells. Then you guys can be able to chip in and tell me about the white blood cells, I think. And we'll have a bit of a discussion around platelets, because obviously for trauma, those are very important. And talking about how blood loss is controlled, which again will then relate to in the future when you guys have decided that you're going to be, I don't know, off on HEMS helicopters, or you're going to be working in primary care with some complicated patients. That's where the more interesting work is, ladies and gentlemen, okay, etc. Okay, this is where you'll be looking at how that relates back to what you want to do for your patient. And we'll have a little look at ABO and rhesus-D, which again, I think you should know a little bit about from when you did some genetics with Adam. So this is our section on blood, and we've got some other learning objectives for lymph further down, plus a cute vampire. So these are your components of whole blood. So this is when we take a hematocrit, which I'm sure everyone's heard on TV, etc., when they're doing sort of sciencey stuff, and you can tell that actually it's a little bit made up. This is what this actually is. So they take a vial of blood, you take a vacuum container of blood, whop it in a centrifuge and whiz it around lots and lots and lots, and everything separates out. So at the top you have the plasma, which, as you can see, takes up 55% of your whole blood. Then you get this layer, which is actually thicker than it appears in this picture. I've got a nicer picture of it further on in the presentation. And this has, if you're a 90s kid like me, the best name ever. That's the Buffy coat. Okay, and yeah, I don't know if that's the inspiration for the vampire slayer, but I like to think it is. Okay, and that's where you'll find all your white blood cells, and you get to that fight infection as well. So it's quite apt. Okay, so that's what that little bit in the middle there is. And at the bottom, you have your red blood cells. Okay, so there's a bit of variation there. So for a male, you should have 47% plus or minus 5%, whereas for a female, it's 42%, again, plus or minus 5%. And the difference there is due to testosterone. So testosterone will stimulate the kidneys to produce more erythropoietin, which then stimulates the production of more red blood cells. So males actually do have more red blood cells than females, but there's not a dramatic difference. So that's an overview of what whole blood is made out of. And this is quite a nice summary sheet, really, I think. So you have your formed elements over here, which are essentially the bits that you can sort of view as solid-y bits, technical term there. And everything that's sort of dissolved and in the fluid is within the plasma. But that also includes things like cell fragments as well, you'll find in there. Got your blood gases there, got hormones, waste, some degree of oxygen as well. It's not purely in the red blood cells, some carbon dioxide, etc. So there is a little selection of extra there. So, everyone happy so far? Anyone else as charmed as me by the name Buffy Coat? Okay. Good. Even if you are just humouring me, that is good to hear. Okay. So what we have for the functions of blood is broken down into 3 different categories, really. So you've got your distribution, which I think you guys are all generally really quite happy with. Regulation as well. So we've got for maintenance of fluid volumes within the circulation, we've got proteins in the blood that prevent the loss of fluid from the circulatory system into tissues, because you've got to remember that your osmotic pressure. So if you think back, does everyone remember when we were discussing sort of high concentration going from low concentration across a partially permeable membrane? Is that familiar to everyone? So your osmosis. So osmosis will be essentially pulling fluid from the circulation. So we have other mechanisms that keep the fluid where it should be and keep everything balanced. Good stuff. Okay, so we have that. We have maintenance of temperature, which is really important to remember if you go out to, again, a major trauma patient. As they're losing blood, they're going to be losing temperature. They're going to be getting colder, and that is going to promote coagulopathy, which is going to cause them to lose more blood, and it's a really vicious circle. So it is very, very important. Do you remember that temperature is a big function of blood? Okay. Helps to maintain the pH in body tissues. So we've got proteins and other dissolved solutes that we can use as buffers there to maintain our acid and alkaline balance. And that's really important to how we transport oxygen. And I've got a nice graph to help explain that on the next page. And it's a reservoir for bicarbonate ions, which are essentially what we use for a lot of this buffering, because that's our alkaline reserve. So if you end up with too much carbon dioxide, your blood will become acidic. And these bicarbonate ions will help to balance that. Basically what's going on there. And they help to protect us as well, which I think is fairly intuitive with white blood cells and antibodies, etc. And with clotting and keeping the red stuff that should be on the inside, hopefully on the inside. So we'll start off by talking a little bit about red blood cells. Okay, so these are, they start off, they're produced with myeloid stem cells, which is something that sort of in further years you'll hear discussed a little bit more as well, particularly in sort of terms of conditions like, for example, leukemia. Okay, so myeloid stem cells, okay, which are present within the bone marrow, okay, and these myeloid stem cells, they divide and they divide, and basically that produces the precursors, so the progenitor cells. Okay, so the progenitor cells will become red blood cells, okay, as they're going forward, and then they become peripheral blasts. So at this point, they still have DNA within them, okay? So as those peripheral blasts, and that's basically how we assess that they're not true red blood cells yet, if they've still got DNA within them, they'll go on and keep developing and keep synthesizing the hemoglobin, because that's what they need that DNA and RNA for. Okay, so after about 4 days, they've shed their nuclei, so they've shed their DNA, and that's when they're becoming normoblasts, and that's when we're starting to consider them as on their way to red blood cells. And this is how we can tell when we're, again, assessing, for example, a patient with leukemia, how young or old those red blood cells are. We're looking at whether there's DNA in there, whether there's not, how many are there in general circulation, because we don't want to have a great many of them with DNA in the circulation. That's a really, really bad sign, etc. This is what we're looking at here. Okay, so after about 4 days, they're shedding the nucleocytes. Okay, and at this point, they still can only contain about 80% of the hemoglobin that will be within a red blood cell. So they're going to keep on synthesizing that hemoglobin for about 3 more days. And the way they're doing that is that the cytoplasm still contains RNA at this point. So that's how they're able to keep synthesizing that hemoglobin. Okay, so once they're at this stage, they'll move to the bloodstream, and 24 hours later, they've lost that RNA and they'll be fully functioning red blood cells. Okay, and that's how you make a red blood cell. So it doesn't take very long in health at all. Okay, and like any way of making anything at all, it can obviously be limited by what ingredients you have to hand. So say, for example, you're short on B12 or folic acid. So these are both really important to the synthesis of new red blood cells. And then you'll have decrease in the amount of red blood cells that you have. Obviously, iron is really important, but we recycle it when we break down our previous red blood cells. So you don't need as much proportion-wise from your diet as you do of your B12 and your folate. You're happy with that? So it's really, really quite a cool system, and it does also respond to demand as well. So your kidneys produce erythropoietin, which stimulates all of this to start, and it will produce more of it if we require extra. Okay, so say, for example, you decide you're going to move to the Himalayas or do a lot of skiing just for fun. Okay, and you're there for a very, very long time, you'll produce more red blood cells, okay, because the pressure there it makes the air thinner, that's what we call it. Basically, it makes it so we can't absorb oxygen so readily, so you require more red blood cells, and the body will produce them, okay? So we can actually produce 3 million cells per second to the power 10, which is just a massive number if you stop and think about it, if we're suffering from hypoxia. So anyone think of people who might take advantage of this particular mechanism to excel at something? Kind of think of who those people might be. Absolutely, spot on. Yes, runners, swimmers, athletes, and you are quite right. It is essentially legal doping because it's really hard to pick up on because we're using the body's own mechanisms. Yes, Lance Armstrong. So what you hear, if you hear about athletes spending an awful lot of time in a bariatric chamber, but they don't actually seem to have that much of a sports injury, that's what's going on here. Okay. So they also consider doing it with astronauts, but there's some concerns about that in case they make the blood too viscous and they're in an area where obviously they're not going to receive optimum healthcare. There's an interesting aside there. So this is what the inside of a hemoglobin molecule looks like. See, that is the American spelling there. And hemoglobin, we've got 4 chains within each molecule, 2 alpha and 2 beta chains. Okay, and that makes up a heme group. So what we have inside a red blood cell is approximately 250 million molecules of hemoglobin. Okay, so it can transport approximately 1 billion oxygen molecules. And just the numbers are staggering alone. And they're really, really clever, really well engineered. So they're flexible, so they can squeeze through spaces and get through small capillaries, hopefully without causing any blockages. And that's due to lots of proteins, but particularly spectrin, which is present in the cytoplasm, which just allows them to manipulate through. So if you think of a condition that people might have, that doesn't always work properly. Absolutely. Sickle cell. So in sickle cell anemia, what will happen is they become crescent shaped, which, in case you guys aren't up on your farming imagery, is also the same size, same shape as a sickle, and then they cause blockages. Okay, so that's genetic disease which affects the production of these proteins, particularly spectrin, and that's why they suffer from this problem. The other thing that I think is really cool about them is they don't use up the oxygen, so it won't get used up within the red blood cells. They can produce their own ATP by glycolysis. So this, again, is something to remember if you go out to somebody who's been referred for what's called an HbA1c, which is a blood test which is looking at the amount of sugar that's been within your red blood cells. But instead of it being like when we do a BM and we just scrape someone's finger, what it does is it gives you an idea of what their sugar levels have been like over the entire month, okay? Because that's going to the life cycle of the red blood cells. So that's the big blood test that we have a little look at if we're trying to work out how compliant people have been or been able to be. They say, for example, it'd be quite important in a diabetic who's been really very unwell. And obviously when you're unwell, your sugar levels come out of whack. So we want to have a little look at how much control there has been there. It's very important if we've got diabetics who aren't compliant or able to be compliant. So if you get somebody who's newly diagnosed, but they're also suffering with dementia, they might not be the world's most reliable historian, but we do need to make sure we give them optimum healthcare. This would be one of the tests that we would use to guide this, and they'd have more frequent HbA1cs. Can also get it as a response to some cancers as well. We'd ask for this test quite a lot because certain cancers can affect how well your body processes sugar too. Okay, so that's a blood test you might see quite often out and about. But back to erythrocytes. 95% of the protein in them is hemoglobin, which I don't think would be a surprise to you. Okay, and that is the important one for us. So hemoglobin is really important to us because it carries oxygen. And this is a graph that has a little look at the uptake. So this is the oxyhemoglobin dissociation curve. So at the bottom, we've got the increasing partial pressure of oxygen, okay? And at the y-axis, okay, we've got the saturation of O2. So, and I think this is really quite a nice curve to have a little look at here. So where we've got a low partial pressure of oxygen, you can see that that angle is actually quite steep and we're quite quickly taking on oxygen there, okay? And that's due to several factors, okay? It is the partial pressure of oxygen, okay? That is very important. So the area where the partial pressure of oxygen will be highest within the body is obviously the lungs, which is really important because we want that oxygen to go from the lungs around the body, okay? And then as we travel through to other tissues, that partial pressure drops because they've got less ready access to oxygen because it's only coming through the blood, and they've got the carbon dioxide there as the waste product from the metabolism. Okay, so then this curve starts to slow, okay, that affinity, and that's what allows the red blood cells to hand over the oxygen to the tissues in the body, okay? And as we go on, we hit a saturation point here, and that saturation point is where there's no more hemoglobin available to pick up any more oxygen. So that's a big part of what creates the oxyhemoglobin dissociation curve here, okay? So Another factor is the acidity as well. Okay, so what you'll find is as we're beginning to increase the alkalinity, actually there's more adherence of oxygen for us, and we're able to pick up more and more oxygen, which again will make everything slightly more alkaline, and that will pick up that curve too, which again is quite important to remember in, for example, trauma or your very shocked patients, because they pretty much always suffer with acidosis. So they're going to have slightly more acidic blood, so they're going to be just that little bit less efficient at picking up and transferring the oxygen across. Okay, that makes sense? You happy with that as an overview? Okay. So just remember the main trends. I don't expect you to necessarily remember the chemistry behind it, which is why I've not gone into it in great depth. Obviously, if you are a chemist, you can really go to it. But those are the important things as per patient treatment. Okay, so oximetry. Everyone happy with roughly how a pulse oximeter works? Yeah. Brilliant. Okay. So basically, just to recap, just in case I have the very confident people feeling happy to reply here. Okay. Oxygen, when it combines with hemoglobin, changes the shape of the hemoglobin, as you can see in that picture. Okay. And what we're looking at when we shine that red light through our patient's fingers, okay, and it goes through and there's a sensor the other side of the finger and they don't have any nail polish on or really cold fingers or anything that's going to cause us chaos. That light goes through, the shape of the oxyhemoglobin reflects that red light, so a lot of that red light reaches that sensor on the other side, and that is converted through lots of very complicated maths that I personally cannot do into a high percentage for oxygen saturation. Whereas if we have a lot of deoxyhemoglobin, that shape will absorb that red, okay, and will reflect blue instead. So less of that red light reaches the sensor, and correspondingly we get a low percentage. Okay, so that's a very basic overview of pulse oximetry, but that is how this works. So hemoglobin binds really very easily with oxygen. Okay, deoxyhemoglobin, that is actually burgundy rather than bright red. Okay, so I don't know if anyone's seen yet sort of a spurting arterial wound. You will at some point, I promise you. Okay, and that is bright red blood versus sort of, you've all seen the very sort of quite dark blood you can get when you take, for example, when you take a BM, particularly in quite an elderly person who might have a little bit of impaired circulation, and that can be really quite dark as a contrast. So what you get with this burgundy blood, if you look at your own arms or wrists, probably notice, I don't know if you can see it on the camera, I've got some quite blue veins there. Yeah, that is that burgundy blood looking blue through my blood vessels, basically. Okay, so that's why veins appear blue. So, as a quick overview, you see carbon dioxide is also carried in the blood. So what we get is we get carbanohemoglobin. That's only sort of 20 to 23% of the carbon dioxide is actually carried on hemoglobin. 70% of it will be a bicarbonate in plasma, and 10% as free carbon dioxide in the plasma as well. So actually the majority of our carbon dioxide isn't carried within our red blood cells. Okay. So what you can get if you have a high concentration of carbon dioxide, so has everyone seen Apollo 13? If not, it's a really good movie. I do recommend it. Okay, and you know how everyone was really, really worried about the astronauts having too much carbon dioxide within the capsule with them. Is familiar? Okay, so the reason they're worried about this is because there's something called the Bohr effect, which is BOHR. And what that does is it can shift that oxygen association curve, okay, by reducing the pH. Okay, so when it reduces the pH, it changes that level of acidity and it changes how able the oxygen is to transfer across into the red blood cells in the lungs. Okay, if there's too much carbon dioxide within that air that we're attempting to breathe in, because obviously you should have quite a proportion of carbon dioxide within air. I think it's about 21%. Okay, I'm thinking back to my own GCSEs here. Okay, if it's too high, that association curve will shift and we're less able to pick up the oxygen. So that oxygen might actually be in the air, but actually there's too much carbon dioxide for us to use it. Okay, and that's due to the Bohr effect. So that's why if you go out to somebody who's had an awful lot of smoke inhalation, you're going to be thinking, well, let's pop you on some oxygen just to reverse those pressures quite quickly and get that oxygen back into your bloodstream where it should be. And you can ask the fire brigade to carry carbon monoxide monitors. You can ask them to pop them on and have a little look for us, because we can't tell the difference between oxygen and carbon monoxide with our sensors. Okay. So, yeah. So basically with that oxygen association curve, having a high amount of carbon dioxide in tissues is a good thing because that allows that exchange to take place. But if it's in the lungs, that's not, because that will stop that exchange from taking place as it should. Okay. So I'm just going to pause there for a second. We don't have the ability to monitor it within the blood, so we can't do it as we would with sort of SpO2. There are some on main stations. What you can do is you can request somebody go and pick one up for you. So it might be a team leader that you get on a car to do it, or usually it's the kind of request that they'll send down to you when you're on the car and you go grab it and bring it back if needed. But for most events where you're likely to have a problem with carbon monoxide, we're going to have the LFB there anyway, and they do carry that monitoring because obviously they're more likely to be exposed, so we generally just borrow theirs. Yeah. It's one of those things where we don't need to buy our own because we can just nick them. Cool. Okay. Which brings us on to other people who can nick things, and those are very small people. Arguably smaller than that one in the picture, but that was the cutest picture I could get up. Everything else I Googled looked a bit strange and disturbing, if I'm honest. So this is looking at fetal hemoglobin. So fetal hemoglobin starts being produced from approximately the 6th week of pregnancy. Obviously, one of the issues there would be that we quite often don't know what week of pregnancy our patient is if it's that early in the pregnancy. Okay, but it becomes significant within their hemoglobin sort of round about week 12, okay, which is when the expectant mother normally does know what's going on by that point. Pregnancy's normally been dated. Okay, and once it reaches that high level, it will remain high until baby is somewhere between 2 to 4 months old. Okay, so if you're treating a very, very little one who you've come out to, I don't know, a house fire or somebody's had a boiler problem and you've got the entire family, obviously you're going to be very, very concerned about those little ones. But that is a small advantage you have if you're treating a very, very little one. Actually, if you can get the oxygen in them, their fetal hemoglobin will pick it up very well. That's a good thing. By the time they're a year old, that advantage will have totally gone and they've got the exact same hemoglobin as you or I. Okay. But it can be really quite problematic if you're going out and they're still in utero, so the mother is also your patient. Okay, so we're looking at protecting the mother. We're providing with oxygen, but she's not retaining as much of that oxygen. Say, for example, she's a trauma patient, she's lost a lot of blood, so she's got less of her own hemoglobin going around. We're putting her on oxygen. We've managed to, well, we're trying to stop that bleeding, okay, but we're not totally able to. We're bluing into hospital. What we do have to be aware is an awful lot of that extra oxygen that we're giving her will be going to baby instead of mother, okay? And this is why very, very unwell pregnant ladies, okay, if the baby is at a viable age or if baby is not, but we can obtain consent, potentially she will have a cesarean, okay? This is why, because she's losing that oxygen. Okay? That makes sense. Good. Yeah. Would you give her more oxygen? Yes, under those circumstances, you're going to be giving her sort of high flow O2 anyway. So yes, absolutely. And you might have a slightly lower threshold for a pregnant trauma patient to give her some oxygen as well. So yes. The other thing to remember is if you go out to a delivery, okay, and obviously most deliveries do go very, very well, okay. I hasten to add that because I do know a lot of people in the ambulance service don't particularly like delivering babies because, you know, all of a sudden your number of patients just doubled and the team you've got didn't double. So I do understand it. If you have to resuscitate a neonate and they're still attached to mum, leave them attached because they can use her lungs and they can steal that oxygen from her efficiently, make it much more likely that we'll get a return of spontaneous circulation. So long as mum is well, leave them attached, okay, because mum's body is able to support them so long as she is healthy. Okay, practical terms there. So the other thing we can do, actually, and this is quite cool, they do this in Lewisham a bit, is they collect some of that fetal hemoglobin from the umbilical cord when babies are delivered, and they can use it as a treatment for sickle cell, which is quite cool. It'll treat the symptoms in the short term, but it's very, very effective, which is, I think, quite cool way of utilizing this. Right. So red blood cells, to break them down, they get broken down in the spleen and the liver. This diagram just has a picture of the liver, but it happens in both. And they become fragile with age, which is why we need to recycle them. So what will happen is they get phagocytized by what's called Kupffer cells, which are really very aggressive macrophages, and you've got a lot of them in your liver and your spleen. And they will break down those red blood cells and split up that hemoglobin molecule into heme and into globin. Okay, so globin will go on, broken down, and will be used as an amino acid. The heme will be partially recycled. The iron can be returned to the bone marrow to then be recycled and put into more red blood cells. And some of it will be broken down into, we've got biliverdin. So just remember that that's actually the first stage before it becomes bilirubin, okay, because you might occasionally hear that discussed, okay? So basically it goes green before it goes red, okay? The end product is bilirubin, which is why you'll normally see diagrams like this. I've just added biliverdin in with the green arrows to remind you, okay? And that bilirubin, again, will go to the liver. It might already be in the liver because the liver might be where this erythrocyte got broken down. Okay, and it'll be excreted in your bile, okay, into the gut and out. Okay, if you have too much bilirubin, okay, and you're not able to excrete it all out in this way, what you'll find, do you know what you'll have? Jaundice, absolutely, yes. So you get that build up of bilirubin, and they'll start to look a bit yellow. Okay. So got here is I've got a few conditions for you. So in terms of categorizing them, the ones that are in this darker color here, those are the ones where you've got overall too much destruction. Okay. Here, what you've got is either not enough production or not enough opportunity to use them, which is what's going on here. Okay, so too few for that reason. So these are an overview of pathologies that will affect your red blood cells. Okay, so hemorrhagic anemia, how else would we describe that? Yes, absolutely. Anemia caused by blood loss, and one of the more common causes is heavy menstrual flow. Yes, absolutely. Okay. Yes, a loss of erythrocytes secondary to hemorrhage. So this is going to be our significant blood loss going on. So by menstrual flow here, we're talking about perhaps endometriosis. So we've got an awful lot of blood loss going on. Okay, so we've got a hemorrhage there, so there aren't enough red blood cells. Okay, so yeah, absolutely. What about aplastic anemia? People know what that one is? I'm thinking resounding silence means no. So basically, an aplastic anemia, it's quite common to be secondary to another condition, usually autoimmune, but not necessarily. Okay, and what's happening is you're not producing enough red blood cells, and you're usually not producing enough white blood cells or platelets either. Yeah, so they don't form, absolutely. You've not got enough of them. Do the job. Okay, so that's your aplastic anemia. So what we need to work out with those is how severe it is, does it require a transfusion? Two, what is the overall cause? Okay. Pernicious anemia. Yes, 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 absolutely. So this is associated by not having enough of the building blocks for your red blood cells. Okay, so usually what you'll find is you're not able to utilize enough of your B12 because you don't have enough of your intrinsic factor. So intrinsic factor is a glycoprotein that's produced in the stomach by those parietal glands. And if you don't produce enough of that, you can't absorb the B12 from the diet. Without the B12, you can't then form any red blood cells. So that's what's causing that deficiency there. Okay, it's normally, again, caused by an autoimmune disease. It can be associated with stomach cancer. So it can be if you've got someone who's coming to you who is being investigated for pernicious anemia, and they say actually they've had some abdominal pain too. Just have that in the back of your mind, okay? Because symptoms of stomach cancer are quite non-specific because abdo pain is very difficult unless it's one of the sort of classic presentations to diagnose. Okay, so just have that in the back of your mind. That's probably what they're being investigated 4 is a matter of urgency there. It can also be associated with the damage done by parasites as well. So, for example, tapeworms are a big culprit here. And that's why, you know, how every now and then you hear the story about the tapeworm that's managed to end up in the lungs. And then once it comes out, everyone goes, oh, yes, I know somebody who had that. I know somebody who had that. Yeah, that sort of urban legend thing. It's one of the urgent, yes. And a lot more of you will hear a little bit of this going forward. Actually, what it is every now and then you do get the rare tapeworm that does manage to emigrate somewhere where it shouldn't. Extraordinarily rare. And then people think that it is more common because tapeworms can cause damage in the stomach to those parietal cells. So they then don't produce enough intrinsic factor, don't absorb enough B12, don't get enough red blood cells form. The oxygen's not transferred around the body, and obviously they become quite oxygen hungry as a result because it's not being transported on. So they show all the signs of trying to breathe a bit faster to compensate. And because it is caused by a tapeworm, people then sort of join the dots erroneously and think that actually the tapeworm was in the lungs, where actually this entire problem started and remained in the stomach. Okay, so that's where that bit of urban legend, that's why it propagates. Okay, it's a tapeworm ending up, well, I don't want to say the wrong place because obviously we don't really want them in the stomach and the intestines either, but ending up anywhere else is incredibly rare. Okay, so that's what happens there. So iron deficiency anemia is pretty much what it says on the tin. So it's either going to be low intake, in which case we can fix it with diet, or low absorption, okay, which is more of a problem, and that's usually linked with IBS. So if you've got an IBS patient with persistent anemia, that's what's going on there. You can also get it for increased loss that we don't put down as being truly pathological. So this is where you get this overlap between your hemorrhagic anemia here, because an iron deficiency anemia would be normally where we would characterize, for example, somebody who suffers with anemia because they have very heavy periods, but arguably would be right to categorize it as either. So I'm sure you can all see the logic behind those. Okay. Renal anemia. Yes, absolutely. So you get not enough erythropoietin, okay, and because of this, you're not going to be producing those red blood cells. So these will usually be patients who will be treated supportively with potentially transfusions while we work out what's going on. Again, quite commonly it is autoimmune, and we attempt to stop that autoimmune problem. So it might be somebody who'll end up on long-term steroids, for example. Okay. Thalassemias. Do people know about those yet? Oh, can they get erythropoietin as in doping? They do sometimes try treating them in bariatric chambers, yes, to increase the amount. The issue we get is it's generally an autoimmune response that has caused this in the first place, which makes it harder to treat, whereas the athletes who are able to manufacture excess in sort of a doping manner are very healthy and obviously able to compensate and produce more, so it'll be less efficient for them. and it depends on the severity of the problem in the first place. But yes, absolutely. Occasionally you will hear of patients who are transported to Whipps Cross for this, which is where we have a bariatric chamber. And yes. So yes, it'd be symptomatic management whilst we see essentially what else is going on. So absolutely. Good thought. Okay. So we go on to thalassemias. Does anyone know anything about thalassemia? Bit of a rare one. We're quite lucky in this country. It is, yes. Yes. So they're defective because this is it's basically a disease of the hemoglobin group, and it'll be specific to one or the other hemoglobin chain. So you either have alpha thalassemia or beta thalassemia. Okay, and yes, because these chains are defective, we're less able to transport oxygen around the body. So essentially, the red blood cells might be about 50% as efficient as everyone else's. So this, again, is a very difficult condition to treat because essentially you have to look at replacing that coding for the red blood cells, which would be a very, very high risk strategy. We'd be looking at bone marrow transplants, which obviously is quite risky. So again, we usually do manage the symptoms. Occasionally, again, these guys can be supported theoretically with fetal hemoglobin, but obviously getting enough fetal hemoglobin to support someone would not be long-term feasibility issues there. Whereas for sickle cell anemia, you'd be using it for a particular crisis, which makes it more likely, and even then it's incredibly rare. Charlotte's typing. It can be within, for example, a family. It's not one that they take the umbilical cord for because they're going to use the stem cells later in life, though. So it's not one of those. So say, for example, when a baby is born, sometimes the parents will have the umbilical cord frozen. And what they're looking at is they're looking to preserve those stem cells so that essentially that child has an ideal donor should they ever require a bone marrow transfusion because it's themselves, so it won't be rejected. So that's the logic there. Here, this won't work because we've already got whatever's gone wrong with the bone marrow. So usually we'd be thinking of perhaps a leukemia, which is where something will go wrong with the bone marrow a little bit later in life. Obviously, you do get childhood leukemias, and then they could use that umbilical cord to reset the immune system for them, and it would be their own. So it would be absolutely perfect for them. However, just in case you do go out to people who are planning this, for it to be successful, you do have to get the patient to a stage where they're able to receive said transplant. Okay, which is incredibly high risk. So although we have reduced the risks of rejection virtually 100%, that doesn't mean that they're necessarily going to have a good prognosis. Okay, cool. Okay, right, sickle cell anemia. Is everyone happy with what sickle cell anemia is? Because this is one that you will go out to. Okay, so yes. Okay. Yep. So pop an explanation up, everyone, just in case there's somebody there who's thinking, oh, I don't want to be the only person to say, oh, I'm not 100% happy with this. So what is it and what might precipitate a crisis? Okay, I've got a can you explain it, please? Brilliant, well done for being honest and saying, because vasoconstriction. You others typing. Oh, yeah, as in precipitating cause, absolutely, yes. Yes. So hemoglobin is sickle-shaped rather than concave. Spectrin isn't produced as much as you have blocked in capillaries. Any advances? Yes, absolutely. It may have a function. Yes, this is very good. Doesn't bind with O2 properly. Yep. Yes, very painful. Absolutely. You go out to these patients. You're going to be thinking about giving them some morphine when you're able to. It's very painful. Yes, low temperatures. Yes. Okay, so it's an inherited disorder, and yes, evolutionary adaptation. Yes, so you're quite right. This is, as we go through, we've all got roughly the same genetic code, and then we get mutations. How widespread they become through the population, as I'm sure you all know, depends as to whether they're advantageous or not. So say for example, the thalassemia we just discussed, that's not advantageous at all. Whereas sickle cell anemia can be advantageous in certain areas. And John, you're quite right. It's advantageous if you happen to live in an area that is prone to malaria. Okay. So the reason it's advantageous is what sickle cell anemia does is instead of having all of these proteins, particularly the spectrin, that make these biconcave discs nice and bouncy, so when they squeeze through a small gap in the capillary, they ping back into the right shape. People who suffer with sickle cell anemia are less able to do it because they don't have the right coding for these proteins. So if there's stress on the body, okay, and there are various different types of stressors, these red blood cells won't ping into the right shape. Instead, they'll collapse into a sickle shape, which is like a crescent moon. Okay, and because they can't get back into the right shape, they now can't flow through the blood vessels as they should, because that biconcave shape is ideal for flowing through, not creating too much turbulence, so not adhering to the sides of vessels, not causing blockages, and for being able to get through. Okay, that sickle shape is not, so we get blockages in the capillaries that stop them from being able to go through. And obviously anything that will increase the amount of blockages will also increase your likelihood of suffering from conditions like heart attacks or pulmonary aneurysms, etc. Okay, so you're with me on that one. And obviously if you've got any blockages, that's going to be incredibly painful, and dependent on where the blockage is, that'll depend where the pain is. So that'll be what we're called for in a crisis, because these patients are in an awful lot of pain. Okay. However, yes, I will come to that one. Molly, yep. Do people die from other illnesses caused by it? Absolutely. It can be a contributory factor to a lot of things. So what we get is more prevalent in people of African or Afro-Caribbean origin And the reason for this is the area where we're more likely to find malaria. Okay, because obviously malaria is transmitted by mosquitoes, normally in really quite warm countries where there's a lot of stagnant water. Okay, and we're quite lucky in this country that we don't suffer from those conditions. So we're unlikely to get malaria, although I am told that Oliver Cromwell died of it. Fun fact. But it's advantageous in these countries because of the sickling shape, it damages the receptor that is used for malaria to access the red blood cells, because it's a disease of the red blood cells. So because it can't access those red blood cells, they can't get infected with it, despite the fact that they've been injected with it by a mosquito. So this is why it would be advantageous, because even though you're more at risk of suffering from an MI as a consequence of the sickle cell anemia, that is more likely to be survivable than, for example, malaria, particularly if you're in an area of poor healthcare. Okay, so you're going to have more people surviving if they have the sickle cell anemia. Also, you've got to look at the ages that take place. So malaria will affect across the age ranges, including the very young. So you see, in order to inherit something from your parents, they have to manage to become parents. Whereas the complications that are associated with sickle cell anemia, beyond pain, so the serious ones, those are also made worse with aging, because there are more additional factors that make you more likely to, for example, have an MI. Okay, so this is why you're more likely to pass this on down. Okay, and this is why evolution has allowed it to propagate throughout the population, because it had advantages. It made people more likely to be able to pass their DNA on. Okay, so if you've got someone who's having a sickle cell crisis, and it would depend on how severe the crisis is, and they will know. Okay, so it could be that it's incredibly painful, but they are essentially well overall. Okay, it will cause inflammation, so they may have a temperature. Okay, be very, very painful. But if you're checking their SATs and their SATs aren't overly affected, what you'll do is you either ask them if they're of their own specific passport for it, okay, because quite a lot of sickle cell patients have their own specific passport that says how's best to treat them as an individual, or you follow the JCALC guidance, okay, or depending on where you've got that blockage, they might be having a significant crisis, okay, and it depends how widespread these blockages are. So it can be triggered by all sorts of things, like being too cold, causing vasoconstriction. That can trigger it. Being too hot and struggling to cope with additional heat can trigger a sickle cell crisis. Being ill, the list goes on. Anything that increases stress can make you more likely to have a sickle cell crisis. So you need to assess the patient as a whole, find out what's going on with their health additionally, and treat them. But yes, they will require pain relief. It is extraordinarily painful. Oxygen will help, and taking them to the appropriate centre as well. So we've got a very, very good centre in Lewisham, particularly. Okay. So if you suffer with sickle cell anemia, obviously you're more at risk of things that are life-limiting, potentially like MIs, etc., and can make you less able to adapt to other illnesses. So say, for example, you've got two patients who have a form of cancer that's equally progressed. One of them does not have sickle cell anemia, one of them does. The additional stresses, the additional likelihood of additional incidences can affect their prognosis. Okay, so it interacts with everything that's going on, which is the big risk with sickle cell. And again, it depends where those blockages are. If they're in the lungs, obviously a pulmonary embolism can be a very, very big problem. Okay, so it can contribute to other illnesses, but potentially it could also, in rare cases, but it does occasionally happen, potentially be the cause. So you're quite right, Molly. Okay, so we've got Veronica saying, in these cases, giving them an anti-inflammatory can make it worse. We don't tend to give anti-inflammatories without guidance, and that's because anti-inflammatories do have clotting effects as well, but they usually act on the platelets rather than on the red blood cells themselves. Okay, so you usually refer to guidance from somebody who's got the further details to treat this patient appropriately there. So we don't usually give them anti-inflammatories, but a one-off dose to help with pain would likely have little to no effect. So don't tell them off if they have taken their ibuprofen, they're in a lot of pain, but equally ibuprofen is unlikely to touch this pain. We do quite commonly give them morphine or IV paracetamol. If we're giving morphine, because it has an effect on the lumen of the blood vessels, and again, we want to be a little bit cautious there, it's normally advised that we give it a subcut. Okay, we don't tend to advise IM for anyone who may have a clotting problem, but subcut certainly. That's usually the guidance you'll find in their passports. And that's because if we don't want to go necessarily IV, because we don't want to cause any damage to a blood vessel while they're at that increased adherent state with more potential for adherence. So that's why we're a bit more careful there. But again, we do sometimes give IV paracetamol. They're likely to receive IV fluids. So it's just being very careful with your cannulation. Yeah, absolutely. Yeah, so it's being, and when you cannulate these patients, just make sure that you're doing it in optimum conditions as well. Okay, cool. Right, is everyone happy? Do you feel a bit more confident with this one? And yeah, just be a bit more cautious if, for example, you're called out to Heathrow and you're picking up somebody with a sickle cell crisis from a plane. One, because plane travel itself is stressful and can be a precipitating factor for some people, so you might have sort of widespread instances within their body. And two, just sort of remember to come up with an assessment of how good their healthcare has been up until that point as well. Because obviously if they're coming from anywhere in the world, that can be massively variable. And just please remember that even if they're coming from a very well economically developed country, that doesn't necessarily mean that they have health insurance. So we're very lucky in this country. Yes, it would be. It would be far more easy to get a PE on an aeroplane. Okay. So let's move on to polycythemia. Hey, what is this? Do you know? This is a weird one. We don't see this very often. And if we do, it's usually caused by a medical error in this country. Yes, absolutely. So this is where actually you end up with too many red blood cells. Okay, so not too few, too many. Because you got too many, your blood is overly viscous, and if it's overly viscous and basically increased sludginess, it is more likely that you'll suffer with a clot. So any clotting problem is then at an increased risk. Okay, so you do get this. Some people, it is a hereditary condition, so some people will get it because they have inherited it. Okay, can be an autoimmune condition. Quite commonly, actually, both factors have to coincide for somebody to actually be symptomatic. So the rest of the time, they might just be carrying the right genotype for this. Okay, so going back to sickle cell anemia, just briefly, if you've heard of sickle cell trait, that's somebody who carries one of the genes. They've inherited one allele from a patient that is for sickle cell, but the other allele is normal. Okay, so these people have the protection against malaria, but they do not suffer with sickle cell crises. Okay, well, that's a general rule. So that is essentially the best of both worlds. So these are the people who potentially, because they've had these best of both worlds, have gone on live more successful life from a survivability point of view, and then they have met someone who is also sickle cell trait, and if they've both managed to hand over the sickle cell allele to their offspring, then they'll have a symptomatic child. Okay. But back quickly to polycythemias. So polycythemias, you can also get it as a transfusion error. So if we're treating someone with, for example, packed cells, we overdo it, that can be a problem. Okay, so those are your main conditions. Are you happy with those? Yes, awesome. Good stuff. It's a lot to learn. I mean, the pathologies there, you won't find them, for example, on your exam, but they are things that you may encounter out and about, and people know the term. And sometimes you've got patients who know an awful lot more about their condition than you will, or than you ever will, to be quite honest. But you also get the other extremes of patients who've been told, this is what it is that is making you feel like this, and nobody has actually explained to them what the term pernicious anemia actually means, or polycythemia. So they don't know, they've just been given a label. Okay, so it's ones to know. Okay, right. Oh. So brief overview of white blood cells. We're getting to the part where you guys can speed this up because you know about this. So 5,000 to 10,000 white blood cells in a microliter of human blood. Okay, and the vast majority of some types are not within the blood at all. They've migrated their way out of the circulatory system, and there are two techniques for this. Margination, which is where they sort of stick themselves to vessel walls. Okay, that's true of both the circulation and the lymphatic circulation. And what's called immigration or diapedesis, which is where they interact with endothelial cells in order to essentially worm their way into tissues. And they're attracted to chemical stimuli in order to locate pathogens. So essentially they can be called to attack this. Okay. In the production of white blood cells, it's called leukopoiesis. And they can all use what's called amoeboid motion, which I don't think this is going to play on here. So bear with. Share my screen. Yes. Okay, so can you guys all see my screen? I'm hoping you can. Yes. Awesome, bright. So what I'm going to do is I'm just going to start the slideshow here and hopefully not crash my computer, but we never know. And I'm hoping, I'll give this a couple of seconds, that it will go back. There we go, that's what I want. So if you watch this video, okay. So I'm hoping you all saw that. The video is available on, I'll see if I can work out how to get back to the presentation. The video is available on the presentation, so you are able to watch it yourself. But did you all see that? Yeah, I get the impression that you did, yes. I showed that video to my niece, and she's like, my white blood cells are like jellyfish. She was very impressed. I think that's quite cool. So that is what amoeboid motion is. So basically with that amoeboid motion, the cytoplasm forms this sort of process that just allows it to ooze itself in certain directions. That's how that works. And all of these can do it. Okay. So looking at this is basically how we decide what's myeloid and what's lymphoid, as what stem cells they're descended from. Okay, so if you go out to, again, I'm going to go back to a leukemia patient and they tell you they've got AML, that would be acute myeloid leukemia. Okay, so they're talking about these ones. Okay, versus if you've got ALL, okay, that would be discussing these ones primarily and the effects that they're then going on to have about the body. Okay, so that's the categorization there. So these are granulocytes. Okay, so I know you did a little bit of a discussion about this with Abby. Okay, I'm just going to quickly show these are the granulocytes here within them. Okay, and how we work out what sort of cell it is by which stain they take in. Did Abby discuss this with you at all? This particular picture is showing you what they're like once they've taken on the stain. So a neutrophil will show light purple if it's in what's called a neutral stain, whereas an eosinophil is dark red in eosin stain, which is why it's called eosinophil. Okay, or basically any acidic stain will turn it bright red. Okay, which is why sometimes they're called acidophils as well. Okay, and basophils, they go sort of like deep blue, really deep purple in what's called a basic stain. Okay, so that they're looked at on a slide and usually automatically counted by a very fancy microscope, but it might be viewed by a hematologist as well. And this is what they're looking at. Okay. Yeah, so a basic stain, yes, it is more alkaline, absolutely. So it's basic stain as in base. Good stuff. So neutrophils. So you did about these quite a bit with Abby, I think. So they're mostly within the bone marrow if you're healthy. Okay. If you're stressed for whatever reason, and that might also pertain to sort of an illness causing stress on the body, for example, you might find approximately 5% of them within the blood. And that's fine, that's not concerning. If, for example, you have over 10% of them within the blood, then we're thinking that your patient has leukemia. Okay, it's usually going to be CML that they are suffering with in this case. Okay, so chronic myeloid leukemia. So this is what we're looking at. So they're really quite cool in how they kill pathogens. So they use a respiratory burst. So they metabolize O2 within themselves to create hydrogen peroxide. And that's what they use to kill sort of invaders. They have them within them. And they've got these little spikes on them called defensins that they can use to pierce a pathogen. Okay, they can phagocytize it, and they've used the defensins already to make a hole in it so that they can very quickly put that hydrogen peroxide within the pathogen and break it down within it whilst they engulf it, which I think is quite cool. And they produce an awful lot of pus. Okay, so these are the ones that bring the pus out. So there's some nice examples of pus here. So yeah, they usually live within the bloodstream for about 10 hours, and they'll consume 12 to 24 bacteria during this time. Okay, because they're consuming and breaking down, the waste product from that is pus. So once they essentially rupture, this is what you can get. So we've got a person here in need of some antibiotic eye drops. If it were not quite so advanced as that, they could just go to a pharmacy and get some slightly acidic eye drops instead over the counter. So if you've got some mild bacterial conjunctivitis, that's an appropriate thing to advise them to do. And this here is a paronychia. So if they are smaller, they'll probably go away by themselves with just some topical treatment. One this big, this should be treated at a UCC because otherwise you'll cause an abscess. And if you fancy going into the urgent care world, this is quite satisfying if you're the kind of person who likes to pop spots, because you literally get to just cool it so it doesn't hurt the patient with some really cold spray, and then you just pop it with a scalpel, which, depending on the type of person you are, you might find quite satisfying. Okay. Legal sadism working in urgent care, I tell you. Okay. This is what's going on here. So are you happy with neutrophils? Is there anything you want going over, or do you want to move on? Because I do know you have done them in the immune system too. I'm interpreting silence as you being so happy that you're overcome and you're not able to type to me, just so that you know. Okay, so these, they're about the same size as the neutrophils, and the granules in them work like lysosomes, so they'll dissolve basically parasites these attack. So parasitic flukes like flatworms, tapeworms, roundworms, hookworms, pinworms, all sorts of worms. So these are the ones that will deal with the stuff that's too big to phagocytize, basically. They're also very strongly associated with allergies and asthma. That is a nice little overview of the eosinophils here. Happy with that? And basophils here. So these are very rare, they're less than 1% of the leukocytes, and they contain histamine, so they can bind to immunoglobulin E, okay, and they'll enhance the function of your mast cells as well. So again, associated with allergies here. The histamine will attract other white blood cells as well, to make the immune system more efficient, and they contain some heparin as well to prevent clotting. Okay, so not like a massive amount, but the idea behind it, we think, is they'll prevent clotting in this local area of inflammation in order to make it easier for other parts of the immune system to reach the problem. Okay. Right, are people in need of a little bit of a break? Yes, okie dokie. A few minutes would be nice. Will 10 do? Okay, so we're on slide 19 and references are on slide 44. Okay, but we do have a couple that are primarily pictures. So say, okay. So shall we say, do you want to come back at 1:45? And that gives you time to go for a wee and grab a cup of tea, because those are both very important things to do. Does that sound all right? Excellent. Okay, can you all agree amongst yourselves to not let me, yes, and food pets too, to not let me get started again without recording, to make sure that those who aren't able to stay for the whole of the lecture or who aren't here have access to it, okay? So don't let me go on without recording. Excellent. Right. So, are you ready to roll onwards? Okay. So, basophils are the type of leukocytes that are basically pulling all the others to them. So you've got the histamines that will open up those blood vessels because it causes vasodilation, and you've got the heparin, which actually allows everything to stay running as opposed to clotting to bring everything to them. Okay, and they'll both enhance the function of any mast cells as well. Which brings us on to, these are the largest blood cells. So they're 18 micrometers, which is big for a blood cell. And after 24 hours, they become a tissue macrophage instead. Okay. So they'll attract other white blood cells, they phagocytize pathogens, and they defend against viruses and intracellular bacterial parasites. And they're very, very aggressive. Okay, so they're 3 times as big as a red blood cell, and these are the aggressive ones of the immune system. Okay. And that rolls us on to lymphocytes, which are the second most abundant leukocyte in the blood. They make up 20 to 30% of white blood cells. They're agranulocytes, and they last for years. And they come down into little subcategories. Okay. Most of them are actually within the tissues. They're not within the bloodstream itself, the vast majority. So just to remember, a lot of these are within the tissues. So B lymphocytes. Do you remember stuff about these? There are 10 million different types of them. Okay, so these, they'll specific, okay, so they'll bind to a specific antigen. Okay, they're stimulated by T cells to multiply, so to get more of them. And the multiple B cells will then become plasma cells as well, some of them. Okay, and they can produce over 1,000 antibodies per second that will match the original receptors. Okay, so once they've got these, they can then trap this antigen in clumps to make them easier to target for example, phagocytosis. And if you have the ones that are left over after infection, these are the ones that maintain the memory of that infection. So if you're reinfected, you've then got that immune response ready to go if it's encountered again. So these are the ones that when we talk about how much immunity there is within the population for example, COVID-19 at present, these are the ones that are doing that. Okay. So they're very specific. Happy with that? Yeah, good stuff. Yes, they remember. These ones will recognize antigens that they have encountered before. So they're ready to attack. And T lymphocytes, there are a couple of different categories here. Okay, so again, these recognize the pathogen. And what they do, if you've got the CD4 helper cells, these are the ones that will help mature those B cells into the plasma cells that we saw on the previous slide, and to mature them into the memory B cells. So the CD4 will help the B cells to progress, if you like. They activate cytotoxic T cells and macrophages too, so they sort of stimulate the immune system to do their business. Okay, and there are various different subtypes, and they can secrete different cytokines depending on which immune responses are occurring. So again, they can be quite specific. Okay. We also have what's called CD8 plus cytotoxic cells, which are ones that these are the ones that will attack sort of tumor cells or virus-infected cells. So they attack our own cells that have gone wrong for whatever reason, and they cause them to break up. So they cause the lysis of these cells. That's what they do when they're working well. The other thing they can do, if they recognize anything as non-self, they will attack it. So these are also the ones that are responsible for transplant rejection as well. So if you've got a patient who is on long-term medications to suppress the immune system because they've had a transplant, these are the ones that we are suppressing. And that is why patients who've had transplants are particularly vulnerable at present, because where we're suppressing these cells in order to stop them rejecting the transplant, we're also suppressing the cells that activate those B cells as well. Okay, so the B cells are less efficient because we've targeted these T lymphocytes. Okay, does that make sense? Okay, if they erroneously recognize something as non-self, Veronica quite rightly said, then that will cause an immune disease. So they're strongly associated with, for example, lupus. Okay, if it's going wrong and we're recognizing self as non-self, it will attack the human body. So they are very strongly associated with these. So all nucleated cells have what are called MHC class 1 molecules on their membranes, and that is what they're able to attack. So actually they've got the potential to be really quite versatile. So if they go wrong, that is a big problem. Okay. Also having this category, memory T cells, and what they will do is they will differentiate into, once they come into contact with an antigen, they'll differentiate into CD4 cells and CD8 cells and memory T cells. And the memory T cells, they're very, very long-lived, and what they can do is if they encounter the antigen they've already met, they can all of a sudden they'll be triggered to propagate, to produce more and more of themselves, and those will be the effector T cells, so the attacking T cells, okay, if they've been re-exposed by the antigen. So again, they help to remember. Okay, is that all right? Does that answer your question, Veronica? Brilliant. So these cells are really important because they're the ones that provide the memory against previous infections. We also have natural killer T cells, which I'm just going to mention briefly. They're not the same as natural killer cells. They just gave them a really, really similar name to make it really hard for you all to remember it. Okay, these are the ones that bridge the adaptive immune system with the innate immune system. Yeah, I know. I think we could have done a better job of some of the naming, to be quite honest. And so whilst most of those cells, they work on that recognition of those MHC proteins that I just mentioned that are on the molecules, the natural killer T cells, they can also recognize other antigen classes as well. So once they're activated, they can perform the exact same function of CD4 and CD8 cells, but they're more versatile because they're not purely recognizing that one molecule on the cell membrane of these cells. Okay, so they're the versatile ones, basically. Leads us on to platelets. So platelets are made from what are called megakaryocytes with plasma membranes sealed around them, and they break up and they form these biconcave little shapes, which you can see here. Can you see where like my little red dot is? These ones. Okay, that's what they form in the first instance. So those are platelets. Okay, they don't have any nuclei. They do contain granules with clotting factors in them. Okay, and making them is thrombocytopoiesis, because poiesis is the making of absolutely everything. And they will last for about 10 days. Okay, so they're very short-lived and they're very small. Okay, so once they're activated, they develop these projections. Okay, so that's what the spiky ones in the pictures are. Those are the activated ones. Okay, so in this picture, they've probably been activated because it looks like they've had a little bit of time in a centrifuge and to make it so it's quite a packed slide there, and then they've been put on the slide, and actually being put on the slide has stimulated some of them to activate. Okay, so there's quite a wide range of normal platelet counts, okay, to 150,000 to 400,000 per microliter. Okay, if you've got somebody who is below that, they have what's known as thrombocytopenia. Okay, and those patients, if they sustain a head injury, you do need to treat them as if they're somebody who's on warfarin, etc. Take them in. They should be scanned if they've had a proper bump to the head. Okay. So about a third of the body's platelets are stored in the spleen and other organs, but they also circulate freely, and they can do that amoeboid motion that I showed you earlier. Okay, they'll be destroyed in the spleen to be recycled after that 10 days if they've been unused. Okay. So they are biconcave before they're activated, so they're shaped a little bit like red blood cells, and then they develop those projections, like I said. The reason they're not activated when they're going through the circulation is because the endothelial cells of the blood vessels are releasing prostacyclin and nitric acid, and that deactivates the platelets. So once those endothelial cells are damaged, they stop releasing this, and the platelets become activated because those levels have dropped. Okay, so that's what we're looking at here. That's why platelets start to aggregate or stick together. You happy with that? Just remember with platelets that just because somebody has a low platelet count and they have thrombocytopenia, that doesn't necessarily mean that they're not prone to clotting. Okay, it is possible that they will have the worst of both worlds. That is, not enough platelets to help them should they sustain a major trauma, but actually the reason why they're low on platelets might also mean that the platelets that they do have are not as efficient as they should be, or malfunction. Okay? And if you have the type of thrombocytopenia where they will malfunction, then what will happen is they can aggregate, and it can cause lots of small clots to then be moving around the circulation, potentially causing problems in the microvasculature. Okay, so you can get clotting abnormalities beyond not having enough platelets. Okay, and there are lots and lots of different types of thrombocytopenias. Some of them are so rare that we call them idiopathic thrombocytopenias, even though actually we have worked out what's caused them, but they're so rare that they don't get an official name. It's a big topic. Okay, happy with that? Okay, good stuff. So, no, I said earlier about how the buffy coat was bigger than it was in the illustrated picture. Well, that is it there. I do hope that's why the Vampire Slayer was named. Okay, and what you've got here is the fluid component of blood. So basically it is the same as interstitial fluid and contains everything below basically. So it's really, really important. Okay. So, and we have recently found that transfusing people with this, if they've already had COVID-19, if we give their plasma to a patient who hasn't, we can help them. So it's really interesting research taking place at present. So these are our plasma proteins. So we have albumins who originate in the liver. Okay, most plasma proteins will originate in the liver. Even some of the gamma proteins, the liver contains some lymphatic tissue, so it's always a good guess, that one. So you're asking where it originates. And it's the primary controller of colloid pressure. So colloid pressure is also known as oncotic pressure, so you'll hear the terms used interchangeably. And basically what it does is it displaces water against the concentration gradient, okay, and that is to return water back to the circulation, okay, because we don't want to end up with really edematous tissues, we want it to remain within the circulation. So that's one of the main functions of albumin. So if you don't have the right amount of albumins within your blood, that can cause significant damage to your kidneys. And if you have significant damage to your kidneys, you can end up with the wrong amount of albumin in your blood, and that's a cycle that can just keep going. Okay. So globulins, they, again, from the liver and the immune system, they contribute to the control of osmotic pressure. So osmotic pressure is the amount of pressure that would be exerted by osmosis. Okay, so if you're looking at, depends how steep that concentration gradient actually is between the tissues and the circulation, because we're thinking of that gap between them as our partially permeable membrane. Dependent on what the concentration is between the two, that will affect what the osmotic pressure is. Okay, so globulins are used in order to counteract that osmotic pressure, again, to try to make sure our tissues don't become edematous and that our circulation is where the majority of our fluid is. Okay, does that make sense? Is everyone still with me? Cool. Good stuff. Yes, absolutely. Yes. So if you've got low albumin, you'll get water belly going on and ascites in place. Absolutely. This is why they won't be able to control it. So these are people who we will have to support and replace those. Absolutely. Okay. So other proteins we have alpha proteins and beta proteins, both of which transport lipids and fat-soluble proteins for us. Gamma proteins, which originate from all lymphatic tissue, including the liver. Okay, and essentially that works as a type of antibody for us. And fibrinogen, is one of the factors that is a very significant one that will trigger coagulation. So it helps to form those threads that hold the platelets in place. Okay. So this is quite a nice summary table of everything that we've been through. So thrombocytes is the technical term for platelets, which I think if you stopped and thought about it, you would know anyway because of thrombocytopenia. And here are your normal values as well, so that you've got a reference if you want to go to it. But if you ever are working in hospital and you're ordering bloods, what will actually happen is if you've got something that is outside the normal range, you'll get like a little asterisk on there and it will flag it up within the sample. Okay, but you do need to obviously interpret them for that particular patient as well. So it might be, because this is just the range for the average patient, so it might be that actually we were expecting it to be a bit deranged or not. Okay, but it will flag up any abnormal value for you, which makes life a bit easier. Okay. Charlotte's typing to us. Would we deal with this if we worked in urgent care? It depends. Yes, primary care. If you work in primary care, so say, for example, you're in a GP surgery, then yes, you can order bloods. They'll be sent off and it'll be the hospital that your GP surgery is under, the laboratories that will produce this, and those results will get sent back to you. So yes, absolutely, you'd be ordering bloods, interpreting them. But if you were in urgent care, dependent on the facilities, you can still order the bloods. What you need to do is you need to say where they need to come back to. So usually you would say that they came back to you to show that you're a responsible person and to that patient's own GP, for example. And then when you get the result, you would email the GP surgery, do something to show that you have acted on this and flag them up. Okay, so usually you'd be having, say, for example, a telephone consult with the GP, and you'd be initializing something else going on. So, for example, I once had a gentleman come in with widespread oral thrush, which you don't expect for an adult male, because if it's really, really widespread, that shows the immune system isn't working properly. So that's an issue. You're thinking, well, okay, what's caused this? And there are a few different candidates, anything that can suppress the immune system, basically. So we went through, and based on his recent lifestyle choices, I was very concerned that he might have, for example, HIV. So I instigated the blood test immediately, contacted his GP, explained what was going on, explained that there was a red flag on these and to make sure what's going on, explained to the patient what was going on to make sure that this was all instigated. Okay, so you can also still have an input in urgent care facilities depending on what facility in which you're in. Okay. Cool. So yeah, I highly recommend doing a mix of emergency and urgent care work. It keeps everything fresh and enjoyable, and it means that when it's freezing outside, you can be nicely in a nice warm urgent care setting, and when it's lovely and warm and you're hoping to nip to the ice cream van between jobs, you can do that too. So I highly recommend that. Oh, okie dokie. Right. So clot formation here, I said when we were discussing platelets. So your blood vessel gets damaged, however it's going to get damaged. Those damaged epithelial cells stop releasing prostacyclin and nitric acid, so platelets begin to activate. The vessel itself begins to constrict. Okay, so basically it's trying to make that hole as small as possible to stop more coming out. The platelet plug is forming because those platelets are adhering, okay, and it's coming up to basically start to plug the hole in that vessel. Okay, so it's sticking to the exposed collagen fibers there, okay, and sticking to it. So the platelets, when they're activated, they also release from those granulocytes more activating factors to activate the other platelets around there, so they all adhere and become sticky, sticky, sticky. So fibrin is activated, okay, by the fibrinogen, and that just forms that mesh that holds those platelets and red blood cells in place to form that clot and allow it to harden. Okay, so in simple terms, that's how your clot formation takes place. So if you have somebody who does not have enough of a clotting factor to produce that fibrinogen, they're not going to be able to hold those platelet aggregations in place. Okay, so that's what's happening with haemophiliacs. So if we look at this clotting cascade here, it's actually, so you've got your extrinsic pathway, which sort of is nice and simple and just comes down here, and you've got your intrinsic pathway, which is a bit more complicated. So anything that has A at the end of it is saying that is the active form. So that's the version that's actually doing something. Okay, so if you've got someone who has the classic form of haemophilia, so I'm talking about the most common one, the one that's associated with the stories of Rasputin, for example. Okay. If you've not heard those, there's a song by Boney M all about it. Enjoy, it'll be an experience. Okay, what you'll have there is you've got patients who don't have enough of clotting factor 8. Okay, so because they don't have enough of that clotting factor, they are less efficient at producing the fibrinogen at the bottom here, which creates the fibrin, which creates the thrombus. Okay, you can get other versions. So a more severe form of haemophilia is if you don't have clotting factor 7, because that basically takes out the entire of the extrinsic pathway. So you're solely dependent on the intrinsic pathway, and factor 7 will trigger factor 9 anyway. It will increase. So this dotted line basically says it enhances the effect. Okay, that's what that is for. That's what that's telling you. So it's a very complicated system which we make use of. So the blue ones here depend on vitamin K. So warfarin works in opposition to vitamin K. So these are the sections of the cascade that warfarin inhibits. Okay, and if you take too much warfarin, but not a catastrophic amount, so basically you've taken more than you should, but not so much that we can't treat you, we will treat you by giving you vitamin K IV. Okay, so this is the treatment that we used to have to do quite a bit because if people accidentally ingested rat poison, okay, so the stuff that's in those renticle boxes contains lots of warfarin, essentially, and that allows the rats to bleed internally to death. Cheery subject. But if somebody accidentally or deliberately, but for a different purpose, so say, for example, we used to get it sometimes in some areas when we had forced marriages taking place, and it used to be a way that the forced participant could guarantee that we had to be called. That would be one way they would get to go to hospital for help, because we would have to treat them and the families knew that. Okay, so we used to see that in certain areas a while ago. These pink ones are affected by heparin, and most of if you go in to work on a ward and you've got patients who are quite bedbound to try to prevent them getting clots, they'll be getting a subcut injection usually into the abdomen daily. Okay, this is what we're affecting here, the pink ones there. Apixaban, okay, and all the novel anti-clotting drugs that we see quite often, those affect factor 10A, so here. Okay, that's what they act on, and they stop it working so actively. So as you can see, there's a reason why it's so efficient, because it's right here at this significant point where both the extrinsic and the intrinsic pathways are affected. Okay, thing to remember is that it's not reversible if somebody overdoses, not in the same way that warfarin potentially is, dependent on how much they've taken. Okay, so that's why if you have concerns about a patient who potentially has a dementia and they're perhaps going towards the stage where they are unable to manage their medications themselves, but previously they were, we need to have quite a low threshold of tolerance for this if they're on something like apixaban versus their other medications where actually it's less of a risk. Just remembering to really flag up if you're saying, well, actually, I don't think this patient should be in charge of their medications anymore. I'm going to fill in a vulnerable adult. I'm going to notify their GP. Going to, make sure there's a referral to social services if they don't have a care package or anyone able to manage their medications for them. But I honestly think now we're at the stage where their medication should be under lock and key and administered by the carers. That is something to really flag up to the people who need to put this in place. They're on this medication and it is dangerous if it is not being used appropriately. Okay, great. I'm just going to quick sip of tea whilst you finish. Absolutely. So you're looking at your antiplatelet abrogates there. So what these do is they will stop your platelets from adhering, okay, or further adhering. So they won't bust up a clot. Okay, the clot that has already occurred is likely to stay there, okay, and it'll just soften around the edges, potentially making it easier to remove, because we're stopping the platelets on the edges of that clot from activating and grabbing any more of the platelets to further enhance it. So aspirin works. It's a thromboxane A2, which is in platelets, and that's what we use to that's what's used within the system to get the platelets to adhere to each other. So aspirin impedes that specifically. They all work to impede the platelets, but I don't know what is specifically used for clopidogrel off the top of my head, but that's what aspirin does. The antiplatelet aggregates, so they work on the platelets in order to reduce this effect. So they are for ACS treatment. So if you are, you go out to a patient and you're suspecting that they have an MI, what we want to do is we want to immediately be getting that aspirin into them. So give them that 500 milligram of aspirin. Off you go, chew that, and we get them to chew it so it gets absorbed through the buccal route so that it's being taken on board nice and quickly and taken in, and it doesn't go through that first pass effect where the liver takes everything out. It's going into the source to stop those platelets from further adhering whilst we do our scans. Okay, so obviously we don't do it if we've got worries about causing them to be overly bleedy, so gastric ulcers, etc. No, we won't do it for them. Okay, but otherwise we'll give those, and what it will do is it will go systemically throughout the circulation, working on the platelets, but again, only those platelets that haven't been activated, and the number of platelets, how far the spread is and how many of them are affected, that is dictated by what the dose is, okay, and also partly by whether it's buccal. So this is why we've got the ones that taste of lemon on the trucks, and or whether they're swallowed, in which case they'll go through the liver very, very quickly before it goes anywhere else. Okay. So this is what we have. Remember, platelets only last for 10 days, so we're constantly producing new ones. So if you have somebody who's supposed to be taking 75 milligrams of aspirin daily, but they're not compliant with this, and they've not been compliant with this for a while, only every now and then, essentially it won't be having an effect. So again, it's something to be aware of. Does that help? Brilliant. Right. Yeah, and clopidogrel as well. Have a little look at that in the JR Calc, guys, because we don't carry it in London, but all other trusts carry it. We carry it, and it's dose dependent. So whether you're going to go to the cath lab or whether you're going to thrombolize your patient yourself. So if you work for a patient, if you work for a trust that goes over a wide area and it's got some remote parts, you might end up thrombolizing. Okay, so clopidogrel is dose dependent on what route you want to go, what route you're going to go down. Okay. Okay. So bringing us back to world of science here. Blood groups. So did you discuss these last term with Adam when you did your genetics? A little bit, yeah? Briefly, okay. So let's do a quick reminder for you. Okay, so firstly, what I've put in the corner here, this is the right VAT hetainer for what's called a type and cross match. Okay? So this is the VAT hetainer that you use if you're able to take bloods and you have a patient who you think that they need a blood transfusion. Okay, that's the VAT hetainer you need to fill for the lab. Okay? And they will do what's called a type and cross match. So if we start with the ABO, you can have type A blood, which means that your red blood cells are coated in type A antigens. Type B, which have type B antigens. AB, so you have both of them, or O, which has neither. Okay, so you can be any of the above. So if you have type A antigens on the surface of your red blood cells, you will have anti-B, your antibodies in your plasma, and vice versa. So anti-A if you're group B, neither of them if you're group AB, and both of them if you're O. Okay, so that's why if you're blood type AB, you can, on paper at least, so this is theoretical rather than actual, I hasten to add, receive a blood donation from anyone who's the same rhesus group as you. So I mean, by rhesus, I mean positive or negative. Okay. Whereas if you're group O, you could only receive it from type O. Group A, you could only receive it from A or O, B from B or O. Okay, because of those antibodies. And those antibodies that you have, so say, for example, I'm group A, if I'm accidentally given group B blood, the anti-B antibodies that I have on my red blood cells will force those group B red blood cells that have been given to me to try to save my life, they'll clump together and they'll be of no use to me whatsoever. Okay, that's what happens there. So this is how it's very easy to test for. You just get a smear of blood on some slides. You pop in some plasma that contains anti-B antibodies. If they clump together, okay, we know that that blood is either group B or group AB. Okay, then we do the same with anti-A antibodies on the next slide that we did. And if they clump together, okay, we already knew it had contained group B. It's now clumped together on group A. So it's got both of them, those antigens on those cells, so it must be group AB. So it's a little logic puzzle. And if you did it and neither of them clumped, then that would have to be group O blood. Okay, so that all makes sense, the testing process for that. Really very simply and very quick to do. So with this, actually there are 50 surface antigens on red blood cell membranes. These are just the most significant ones, which is why I said it is a theoretical rather than an actual thing that we're saying that definitely all type A blood, for example, could be given to me. That's not actually the case. It's just that is where we would be looking to find an ideal donor for me. Okay, so when we do that cross match, we do our best to cross match as many antigens as possible to make it less likely that we'll get any agglutinations taking place. So these antibodies that are a result of not having the antigens on our red blood cells, okay, they won't cross the placenta. So that is why some of you might have a different blood group to your mother, okay? Those antibodies, they won't cross the placenta, so they don't really cause a problem. Okay? Sometimes during birth, you can get a few slip across the placental barrier. So occasionally you get babies who are born jaundiced as a result of having some of their red blood cells clumped together, and that will resolve by itself. We just pop them under a heat lamp, keep an eye on them, and once they're pinked up, they get discharged to go home. But it very rarely has any sort of long-term effects or causes any significant problem whatsoever. Okay, so those don't tend to be a problem so long as you're not transfused with the wrong blood. Everyone happy with that? That makes sense. Yes, no? Cool. Okay, brilliant. Okay, so A, B, those are dominant. Okay, so if your dad gives you group A blood, your mum gives you group B blood, sort of an allele of them, okay, you will end up with having group AB yourself. Okay, if your dad has group O blood, but your mum has group A blood and they give you an allele each, okay, and the allele your mum gives you is group A, you will have the genotype, which is AO, but O is recessive, so the blood group you actually have will be group A, like your mum, okay? Yes, absolutely. Groups A and B are codominant. Absolutely, thank you. That was the word I was looking for. Brilliant. So what we also have to consider is we have to consider it's called the rhesus factor. It's called that after rhesus monkeys because that was what was used to first discover this. And it is the rhesus D factor, that is the significant one. So this is what decides whether you have positive or negative blood. So for example, I'm A positive, so I'm rhesus D positive. Okay, so as a result, any of these could be my genotype. So I could be this one, or this one, but I'm definitely not that one. Okay? And
you are currently the only person in this conference.
Is everyone with me still?
You are currently the only person in this conference. You are currently the only person in this conference.
Okay. Okay, can you hear me? I've got a "you're back" from okay. No. Brilliant. Cool. Okay, so where did I get up to before I suddenly cut out and I had somebody tell me, "You're currently the only person in this conference," which was disconcerting. Okay. So some people can hear me, some people can't. Am I right? Okay. Okay, can people hear me? Yes. Brilliant. Okay, so I'm just going to type, can anyone not hear me? Because obviously me asking this any other way wouldn't make any sense, and give people a couple of minutes to respond to that. While we're doing that, can you tell me, where did we get up to? What did you hear up to? I'm definitely not DD. Brilliant. Yes. Okie dokie. Yes, absolutely. Cool. Right. So let's go on from there. Thank you. Okay. So yes. So the capital letter D, which denotes positive, is the dominant gene, and the small d, which denotes negative, is the recessive gene. Okay. So any of these three will result in positive blood, and this one would result in negative blood. Okay. And essentially, the reaction to getting the wrong type of blood is a problem on the second exposure. So it's very like an allergy because it's triggering an antigen response. Okay, so this is why we get this problem if you are going out to a mother who has negative blood, but her partner has positive blood, and so they tested the baby in utero, which they're able to do, and they found out that the baby's genotype is this one or this one, so capital D, small d. Okay, so that baby will have positive blood. Okay, so this is now an issue for us. It's something we need to be aware of, okay, because they're going to go in and get checked over regardless now. Doesn't matter if we deliver at home, we're not saying that this baby is okay, and particularly if, so for example, if you have a delivery at home, it all goes to plan, there are no obvious problems. What will normally happen is the midwife will come out, will check mum over, she might need a few stitches, check baby over and go, yeah, I agree, I think they're fine to stay home. And we all leave very happy, think, oh, job well done, and I haven't dragged anyone off to hospital. Marvellous. That won't happen in this case, they will be going in. Okay, so there's If you've delivered, you've not had any problems, everyone seems fine, convey them in. There's no point asking the midwife to come to you if you know this is what's going on. And the reason for this is because mum may have been exposed to the baby's blood, okay, particularly when the placenta was delivered, because when the placenta's delivered, that's a nice big wound that gives them the opportunity for all sorts of things to then pass back into mum's circulation, which normally isn't a problem because everything the baby's got, it got from via mum anyway. But in this instance, it is a problem because they've got that antigen on their blood, okay? Probably won't cause a particular problem to mum. It won't cause an issue at the time. Okay? If it's probably what cause will be with subsequent pregnancy. So if the pregnancy you're delivering is a subsequent one, you're going to be looking out worried that this might be symptomatic. It may occasionally be symptomatic on a first pregnancy if her delivery when she was born was traumatic. Okay, and I'll come back to that in a second. Don't let me go past it without explaining it. Okay, but what will happen, it will be on the second presentation of positive blood to her. If she's not treated for it with Rogan, okay, that's the treatment that we give for this to stop being a problem. What will happen is the second time she is exposed to rhesus positive blood, so for example, on a subsequent pregnancy, she will release these antigens, which will pass across the placenta because the antigens can pass across, and that will target the fetus and will destroy its red blood cells. Fetus can't survive if its red blood cells are totally destroyed, so it will cause a spontaneous abortion. Okay, so this is, there's some speculation, potentially why Anne Boleyn was never able to have a child after Elizabeth I. So potentially it's changed the course of history for this country. Geeky fact for you. Okay, so it's the second exposure that is the problem. Well, that is the symptomatic one. Okay, but we need to avert this developing on the first exposure. So we need to treat them with Rogan nice and early. Okay, so this is why expectant mothers have blood tests done, etc. However, as you can see on this Punnett square, it is possible for a mother with positive blood to have offspring with negative blood. So it can go the other way around. Okay, that is usually not an issue. Okay. The reason that's not an issue is that even though those antibodies, they will cross the barrier, so long as it's not as a response to something traumatic that's happening during the pregnancy, so long as it is as expected, sort of as the placenta's being delivered or sort of during birth and there aren't other issues going on, what will happen there is that a few of the mother's red blood cells will clump a little bit and be destroyed. And other than that, she's got that increase in volume anyway because of the pregnancy that hasn't yet dissipated. She's otherwise quite healthy. She won't notice a problem and she'll be fine. Okay, so it's only if it is the other way around and if it's the baby that has the positive blood and the mother has the negative blood that we expect there to be an issue. Okay, so that all makes sense. Yeah. Good stuff. So that is just something to just quickly get people to check on the notes, and it will happen every now and then, but there should be a sticker on the front telling you that we're expecting this. Okay, so it's Rogan, which is there. And they'll be expecting it. So hopefully they'll be under a local maternity centre. Obviously, mothers do get to pick which maternity centre they can be under. So sometimes you end up with a bit of a run. But it should be the case that if you phone up, give them mother's name and date of birth and say, this is what I've got. And the moment they type that in, they go, oh, and they'll start telling you what you already know. So you shouldn't have an issue accessing for her. Okay. Which brings us onto the lymphatic system, which is a little bit briefer for you. So what we're going to do is we're going to talk about how it works in relation to immunity and how it circulates the lymph, what lymph nodes actually do and why they're significant. Okay, and we'll have a little talk at the end. I've got a nice glossary page for you which will cover this last bullet point. Okay, so we deal with lymphedema quite a lot. We see it quite a lot. Okay, so that's pitting edema there because I don't know why that picture's the wrong way round. Okay, it shouldn't be too much longer. I'm anticipating it being approximately 15, if that. Okay, so this is pitting edema here, and because it is staying pitted. Okay, what you've got on this side, the reason we know that this is lymphedema, actually, you guys tell me, how do you know that that is lymphedema on this top photo here, rather than cardiac in origin? Absolutely. So it's, oh yes, only affecting one side. It's unilateral. Okay, so if it were cardiac, we would expect it to be affecting both sides. Okay, you might get, for example, you've got someone with cardiac failure who has had some lymph nodes removed in one side of the groin, but not the other. For whatever reason, you might have a larger leg on one side than on the other. But the fact that this leg is completely normal, but this leg is edematous, tells us that this is lymphedema, okay? Because the cardiac system will affect the whole of this, okay? All as one, okay? So lymph is continually going around the body, as is the circulation, which is sort of the origin of the fluid, and it's being exchanged with the tissue fluid. So the fluid from the circulation is going into the tissue fluid constantly. Okay, about 20 litres per day sort of makes its way in and out of the tissue fluid back into the circulation as we go through our day. A good 3 litres of that is returned to our circulation by the lymphatic system. Okay, so it's a significant amount. Okay, so I know you're probably all thinking, hang on a minute, 20 litres, there's only about 5 litres in the human body. Just remember that it's going round and going round and going round. So it might be it's like the water cycle, it might be the same fluid again. Okay, so it's really important drainage function. It also is responsible for the lymphocyte production, maintenance, and distribution. Okay, so it's really an important system. So what we get, just like in the normal circulation, we have lymphatic capillaries, which join together to form lymphatic pathways, which go into larger lymphatic vessels, which will unite with the veins in the thorax. And I've got a picture of that. So you've got a terminal capillary. So all of this fluid goes around and it is pumped around, but there's pumped by skeletal vessels. Okay, and it goes around the lymphatic vessels. So lymphatic vessels are only present in vascular tissue because its job is to collect the fluid that's transferred across from the cardiovascular system into the tissue fluid and return it back to the cardiovascular system. Okay, so it's not in bones, bone marrow, teeth, the brain itself, because we've got that blood-brain barrier, the spine or the cartilage. It's only in vascular tissues. Okay. And then what happens is lymph, which is essentially tissue fluid, okay, so it's water, plasma, proteins, fats, ions, and proteins, is collected up by these vessels, okay, and it's returned to the lymph nodes. So afferent vessels go to the lymph nodes and efferent vessels go from the lymph nodes. Okay, so once the lymph is returned to a lymph node, and those are throughout the human body, what they'll do is there's lots and lots of lymphocytes and cells in there that are basically evaluating the lymph because it contains all the waste products. We're expecting that if we've got a disease going on, we're expecting some of that diseased tissue, wastage, etc. from there to end up within the lymphatic system. Okay, If it finds something, so say, for example, you've got a raging tonsillitis, you all know if we feel here, you're going to find enlarged lymph nodes and they're going to be painful, right? Because we've all had tonsillitis before. Okay, it's the first thing. If, you know, somebody says to you, oh, I think I've got a bit of a sore throat, do you think it's tonsillitis? We all know, we have a little look down the throat, we have a little feel and go, oh yeah, I think you're right. Go see your GP. Go to urgent care, whatever. Okay, so you'll find these enlarged lymph nodes, and that is because the lymph has returned to the lymph nodes, okay, and source of infection has been found, okay, by these cells from the immune system. Okay, so it's triggered inflammation to take place. Okay, because what we're doing here is essentially it's a filtering point for our immune system. It's a good place for our immune system to target any problems there. You are very lucky, Josie, if you've not had this. Don't tempt fate. No. Yeah. Okay. So the lymph nodes will target the vessels there, which will trigger inflammation. So they'll become enlarged, and that's why you can palpate them and you can find them, because normally they're very, very small. Okay, so you can find them. And because they're enlarged, if we give them a good poke, they're tender, you know, it hurts. If you've got a stonking tonsillitis and somebody feels here, it's sore, let's be honest, okay? That's actually a good sign. If you palpate what are clearly enlarged lymph nodes and somebody is wincing, that's a sign that it's probably just a normal infection. If it is not painful, but it is enlarged, that can be an indication that actually this is malignant. Okay, so we would prefer it if people have pain, you know, because also once inflammation becomes present within the lymphatic vessels and the lymph nodes, they become more permeable. So larger particles can get in, including the pathogens, which will then trigger the lymph nodes to become more and more inflamed, which will get more of an immune response targeted to the lymph nodes, but also allows cancer cells to travel across there too. And that's why, because the cancer cells do end up within the lymphatic system, that's why if you have a biopsy, they'll also take the lymph nodes around that area. Okay, so if you go out to a lady who has had a mastectomy on one side, the lymph nodes will have been taken from under her armpit as well, so from the axilla, and you'll be told, no, I've been told you're not allowed to do my blood pressure on this side, you're not allowed to cannulate me on this side, you've got to leave this arm alone and only use the other one. Okay, that's because she doesn't have any drainage there now. Really impaired. Okay, so the lymph nodes themselves, they're exocrine glands. We have hundreds and hundreds of them. Okay, just the tonsillar ones that we palpate are probably the most famous. And mostly they're under 2.5 centimeters. Some of them, again, those tonsillar ones are bigger. Okay, and they contain lots of macrophages and B cells, which are basically there on sentinel duty the moment something gets brought in by that lymphatic drainage system. Okay, so your tonsils, so the adenoids, which is the correct term for what we commonly call our tonsils that we look at if you've got a sore throat and you shine the light off your phone and whilst looking in a mirror to have a look at the back of your throat. Okay, what you're actually looking at are what are called encapsulated lymph nodes there. That's all they are. Okay. And the reason they're there are to try to catch anything that would go on and become a, sorry if you all heard the chimes, that is my calendar remind me of something, that would, so it's catching anything that would then go on and become an infection within the respiratory tract. Okay, so that's why we have them up there. We also have a lot of lymphatic vessels within our small intestine. So what the lymphatic system will also do is it transports digestive fat back to the venous circulation because it can't pass into capillaries, it's too big. So it goes into these special lymphatic vessels called lacteals. They're called that because they're sort of a milky white colour. Okay, and go into the lymphatic system and then they return into the venous circulation via there. So the lymphatic vessels, they run alongside all your deep arteries, you'll find them. And there's more variation with the layout of your lymphatic circulation than there is with the sort of cardiovascular circulation. So that is to say that we all differ from each other significantly in the layout of our lymphatic system, whereas our cardiovascular systems are broadly similar. We all know, we'll all be able to find the radial artery. You know, that's why we all have a radial pulse in the same place. Okay? Whereas this, there are differences. Okay, there's far more variation. But what we do all have is we all have two main collecting ducts. So we have the right lymphatic duct here, and we have the left lymphatic duct, which goes down to the thoracic duct, which is actually the one that I'm talking about here. So it's right and thoracic. Okay, and they will rejoin the venous circulation on the relevant side. So this one that we're looking at here is where the thoracic duct rejoins the venous circulation. And what it does is it's coming in where I've put that star in between where the internal jugular vein is coming down from the neck, and we've got the subclavian vein that's just popping itself in there to be returned back to the heart to come in through the superior vena cava. Okay, and the same thing is going on the other side, except that that would be the right lymphatic duct. So the thoracic duct does the draining for all of this side. Okay, so it's a massive superhighway. The right drainage area is literally just this little bit here. Okay, so it is a massively uneven workload here. So if, for example, you have a significant trauma that's blocking on this side, you are also going to have lymphatic issues coming all the way down here, etc. Whereas if it's affecting this side, it will only affect sort of the right arm and the right side of the head, which is less significant, although still problematic. That is a good question on why it's so uneven, to be quite honest with you. And I couldn't give you an 100% answer. There are a few different answers in various literature, but I couldn't find an absolute agreement. I found several that were variously plausible, and a lot of them thought it had to do with the layout of the cardiothoracic system. And because the left side is more dominant there, that is why. But the additional factors, it didn't explain why, for example, the right leg was not serviced here. So I can't really answer that, if I'm honest. Yes. So the axillary nodes are going to be here, so that would affect the left arm coming down. Okay, but say, for example, were you to have some form of blockage or trauma here, so affecting up here where everything is coming in, because you can see the collecting ducts coming along this way, that would be more serious on the left side than on the right side. Okay, that. Whereas the axillary node, that would still affect the left arm primarily, rather than sort of down here. But you're quite right, a problem sort of in the neck region around the left side in terms of the lymph is far more significant on the left than on the right. Okay. So lymphatic vessels have valves, just like veins, which prevent backflow. Okay, and it's skeletal muscle that pumps the blood around, that pumps the lymph around the system. Okay, so there's not a heart or any sort of pumping organ. So it will speed up during exercise. But if you have a severe infection, what might happen? So if you're very unwell. So yes, so what will happen if it's very unwell, you'll get the enlargement of these lymph nodes, you'll get more and more waste, more pathogens there causing a problem. But Charlotte's quite right, because when you're very unwell, what you tend to do is you tend to curl up in bed. You're a lot less active, aren't you? Okay, so you're not activating your skeletal muscle so much. So that is likely to have an effect to slow down our lymphatic drainage. Okay, so because of that, we're going to have these inflamed lymph vessels that aren't clearing themselves quite so well because they've got a reduced skeletal muscle pump. And we think that is one of the reasons why when we have a very high temperature, we have rigors, okay, or we shiver, and it's to help with that skeletal muscle pump to improve it. So we think that might be the functional reason why we have this. So yes, you are both right. So we also have this mucosa-associated lymphoid tissue, okay, which we mentioned a bit when we did the gastrointestinal system. So these are Peyer's patches, which you get in the small intestine, okay, which are the best known of these. So what we've got is these will serve as a barrier and they contain lots of B and T cells. So you'll have them in lots of places that are really quite open in order to stop the pathogen traveling. So remember that your gastrointestinal tract is completely open. Okay, so that will then allow drainage to lymph nodes to allow for the adaptive immune system to take over, okay, and to treat and to deal with any pathogens. This is why we've got these Peyer's patches in the small intestines. Here, wouldn't muscular tissue be producing energy as the metabolism is increased during infection, creating rigors? Yes, it'll be the metabolism should be hopefully increased during infection to allow you to fight everything off, and muscular tissue will be that and utilizing the energy as well. So yes, that will be creating, that is one of the functions for it, but we also believe that one of the reasons why we have evolved to adapt to it is for that lymphatic drainage. So essentially it's being very efficient. So it's two functions in one. Okay. So what we've got here is the thymus, which I know where you did a lot with Zoe. Okay, so this is where we have the maturation of the T-site lymphocyte precursor cells. Try saying that 3 times fast. And what you've got is you've got a blood thymus barrier to prevent these cells all being activated prematurely. Okay, so when you are a neonate, you've just been born and your thymus is at its largest, you have this extra protection to help you to develop your immune system. And with age, you need less and less of this specific protection that's not allowing the premature activation of cells because your immune system is more efficient. So it will decrease in size, okay, and be replaced with sort of adipose fatty tissues and connective tissues. Okay. So the thymus is significant because it's different from sort of the spleen, the appendix, and your other lymphoid tissues because it has no B cells and doesn't directly fight the antigens. It's almost sort of a resting place to create your fighting reserve almost, okay? So that's why your thymus is that little bit different. Which brings us on to our glossary page here. So remember, afferent lymphatic vessels carry lymph to a lymph node because this is lymph that might well be affected by a pathogen, so it's got to go to a lymph node. Efferent lymphatic vessels carry lymph from a lymph node, okay? So this is lymph that has had the effect of the lymph node effected upon it. So I'm doing my best to make this memorable. I realised that was a bit of a reach. So your primary lymphoid organs will generate the lymphocytes, okay? Whereas the secondary lymphoid organs are sites of lymphocyte activation by antigens, okay? Tertiary lymphoid organs, if you see TLOs documented in patients' notes, particularly a cancer patient, these are abnormalities, okay? So we don't all have, the majority of us will not have them at present. And what they do is they form at the site of chronic inflammation to attract lymphocytes from the blood and lymph in response to this inflammation, okay? So if you have a patient and you're reading through their notes and it says that they're a cancer patient and they have developed TLOs, actually that is associated with a good prognosis, okay, because the immune system is adapting to help fight their cancer. Okay, the other patients who get it quite often are transplant patients too. For them, I don't believe that it's associated with either a better or worse prognosis. Actually, it's the control of the system once control has been exerted that will do that for them. Okay, is everyone happy with that? We got any questions? Is that enough for today? You're all overloaded. Brilliant. Excellent. Okay, so I hope that wasn't too bad. I know it was quite long, and but I hope it's stuff that sort of when you go forward and you actually get to be out and about on placement and seeing some more complicated patients will suddenly start to slot in for you, and you'll see what's going on and be all of a sudden go light bulb moment, go, actually, no, I know exactly what's going on here, and you can really impress your PPEDs. So particularly knowledge about things like TLOs, etc. That's always good when you can crack stuff like that out. Okay, cool. So in that case, have a lovely rest of the day. Go enjoy. It's lovely and sunny here. It's not particularly warm, but it's sunny enough that it's worth being outside. So I'm hoping you guys can go and enjoy the sunshine too. Okay. So have lovely days, all of you. And yeah, be in touch if you've got issues with things, etc. Or also, if you come up with anything that might be quite nice to share for the rest of the cohort and you want it popping on Canvas for you, anything like that as well, so feel free to send it my way and I will do my best with that, or send it to Paul Joyce and we'll try to keep everything nice and interactive. And that also goes for sort of during the summer as well. So we're all checking in with each other during these weird times. So good luck with everything revision-wise as well. So the presentation, yes, that is going to go up on Canvas. What I'm going to do is I'm going to, I have to wait for it to finalize, and then I just need to run it through YouTube to get the closed captions on, which, because there's quite a lot of it, will take a while to do. But yes, it will appear on Canvas, and the PowerPoint itself is there. Okay. Cool. Right. I shall have to run because I now have a meeting at 2 o'clock, but I will, yeah, be available to people if they need to email me and grab me. Okay. Cool. So it was lovely speaking to you all.